and I thank Dr. Dheeraj for giving me this opportunity to talk about the releases and osteotomies for the adolescent idiopathic scoliosis. As with any surgery, we need a thorough preoperative planning to determine a choice of between different sort of releases and the osteotomies. We need to assess the flexibility of the deformity, which is very important to choose between the releases and the osteotomies. And whenever there are two curves or more than two curves, especially like double thoracic, I specifically look at the deformity angular ratio between of the two curves. In the proximal thoracic curves, I always look at the flexibility of that curve because that curve usually is quite stiff, and the amount of correction which we get by the posterior column osteotomies is quite less in proximal thoracic curve. I also look at the kyphosis in the proximal thoracic curve, and I will discuss, why it is important when you plan releases in your surgery. Anterior release, I must admit that it has been an integral part of my training. Having said that, I must confess that I haven't done it in my last more than 250 AIS cases, and we have shifted completely to the posterior surgery for the AIS. Just to complete, just to give you an idea, this is with the short video of the anterior release. We, as we all know, that we all approach it from the convex side. We can do it open or we can do it thoracoscopically. This is an example of a thoracoscopic. This is an example of an open approach. This thing, we take out the rib at the apex, maybe one or two rib higher or lower. You can decide upon the depending upon the deformity, and then you identify the segmental vessels, and you carefully isolate them. You carefully either ligate them, or you either use liga clips to control the bleeding from the segmental vessels carefully. Then you carefully identify the disc spaces, and then we individually take out the ribs. This is like I'm taking out the convex rib head from the vertebra. You have to take it out, convex rib head, which is again a very important part of release. And then you take out the disc from the convex side, from this thing, and then you go through and through to the concave side as well. And then you also cut the posterior longitudinal ligament, and once this is through, then you get a very good release. You can see a very nice release after cutting the PLL and the through from convex to the concave disc release. And once you have done it multiple places, then you can then you can stop it. This is very important because the anterior release is kyphogenic by nature. So we know that the AIS by in most of the cases it has got lordosis in the deformity. So anterior release gives you an opportunity to create kyphosis in that segment. So this is very important to understand. Posterior release is basically the resection of the muscular attachments and the ligaments that comprise the posterior tension band. The soft tissue releases basically involves the interspinous ligament, flavum, the facet capsules bilaterally. We all do partial inferior facetectomies, which we call the grade 1 osteotomy, which I'm going to discuss later. And we also understand that the resection of these structures, they basically results in substantial mobility to most of the curves when we talk about the AIS. When I'm talking about the release of the muscular attachments and ligaments, I usually go for a thorough release. That means that I completely denude the transverse process. I completely cut the capsule between the transverse process and the rib head. So everything has to be done thoroughly to this thing. I also perform the concave rib osteotomies in some of the cases, not all cases, if I'm not able to get the full correction. This is especially very important when, especially in long-standing curves, when these concave ribs, they act like tether basically on the concave side, and just taking out the concave ribs gives substantial mobility in such cases. So this is just short video to show you that I just expose the concave ribs and then just take out the one by one, especially from at the apex. And I usually use the ronger to release these ribs. Coming to the posterior column osteotomies, we know there are different terms: Smith-Peterson osteotomies, Ponte's osteotomies, extension osteotomies, chevron osteotomies. By nature, they all are the same. There are some minor differences. I'm not going to detail. The basic thing is that we can divide them into grade 1 or the grade 2 Schwab osteotomies. In grade 1, we just take out the inferior facet, the interspinous ligaments, and the spinous process. Like shown in this thing, we can either use the burr or we can use the osteotomes. And for a coronal correction, in most of the cases, the grade 1 osteotomy is enough. Just to show you, this is how we perform the grade 1 osteotomies. It has got many advantages. First, it gives you an entry to your pedicle point. It gives you release to correct the deformity. It gives you bone graft as well, and it gives you a clear-cut direction of the pedicle screw in your cases. So this is how we perform the facet release. We take out a sort of triangle area to expose the facet joint or the superior facet of the inferior vertebra. Coming to the grade 2 osteotomies, it is mainly required for the sagittal correction, in which you also cut the superior articular process of the inferior vertebra. It may be required for the large deformities which have got limited flexibility, but in most of the cases it is not required. So this is just to show an example that we also take out the superior articular processes as well. And I always keep the 4 mm, the 2 mm upcutters for this thing, which are required. And now we have got the ultrasonic scalpel. So again, doing a grade 2 osteotomy becomes quite easy with this thing. This is a very useful instrument, what we call as the lamina spreader, and we use it to assess the mobility of our osteotomies. So this is just to show you an example. This is a video where how do we check whether the osteotomy which we have performed is sufficiently mobile or not. This you can see that this is a grade 2 Schwab posterior column osteotomies, and we have got sufficient mobility from the posterior this thing. This is just a correction with the help of the posterior column osteotomy. Then you need not to do it at all the levels. Basically, it is required mainly at the apex and maybe 1 or 2 levels surrounding it, the apex. So this is just to show you an example of a case pre and post. And now we have got the superior instrumentation, cobalt chrome rod. So now our corrections, they are much better. This is an example. This is another case with this thing, which we are using the cobalt chrome, and this is the MESA system which we use. Now, this is a case, in which the growth rods were applied. This was an AIS. I am not sure what was the thinking of the surgeon. She presented at 12 years of age, and he applied growth rods. And at the age of 16 years, she presented to us. And now you can see that the deformity is progressing above and down. So in these cases, when we, these posterior column osteotomies, they come very handy. And when we opened it, the middle of the whole of the spine was fused. There was a sheet of bone there. And then we just did the posterior column osteotomies at above and below, and we connected with the additional rods, and we could get very good correction in this child, you can see. Coming to the asymmetrical pedicle subtraction osteotomies, they have got very limited role in my current practice for AIS. I consider them for the double curves when the deformity angular ratio of the proximal thoracic curve is high as compared to the distal one. So just let me give you an example. This is a double thoracic. This is a double major curve. You can see, and in this case, if I correct the dorsal the lumbar curve, the thoracolumbar curve, then you can imagine that the correction will not be much in the proximal curve, and then the whole trunk will be shifted. So from the start, it is a perfectly balanced curve. And but the amount of correction which we will get will be much more the distal as compared to the proximal if we just go for the posterior column osteotomies. In these sort of cases, I consider the asymmetrical PSO at the top, and I always apply a smaller rod on the concave side, and then after achieving the correction, I look at the amount of correction which is required, and I gradually distract it on this rod, this osteotomies. So it gives me an example of the how much correction I need, as well as the control over the neuromonitoring, and then we can achieve a very good balance in these patients with the help of this technique, the asymmetrical PSO and the proximal thoracic. Coming to the vertebral column resection, for me, it's too much for the AIS. The AIS is usually a smooth deformity, while the VCR is only for the sharp angular deformity. So in my practice, there's no role of VCR in AIS except in revision cases. VCR is okay for congenital cases, for the deformity, severe deformity, like in these cases, but not for the AIS. Uh, Again, in AIS, if you do a small releases and small osteotomies, posterior column osteotomies, bit by bit. So whatever you see is a petty correction coming up at each level. It becomes plenty in these cases. Just to show you an example, this girl, very severe curve. You can see a very sharp razor arm deformity. This was the curve when she presented to the surgeon at the age of 10 years. So it was basically at the borderline of this thing. But when she came to us, she was the age is wrongly mentioned here. She came to us at the age of 14 years, and then it was very severely progressed. The COPS was 127 degrees, and the kyphosis was 94 degrees. So this is the kind of this thing, and it may look when we looked at the images and this thing, then we could make out that there was just within a span of 3 vertebrae. You can see that the vertebrae, they were rotated at 90-degree angles to each other. So there was a 180-degree rotational deformity just within a span of three this thing. So these sort of deformities, they can present with the AIS. People may argue that this may not be an AIS, this may be something else, but we cannot fit it into any other category. So for me, this was the AIS, as we could see the progression of the X-rays, and this was the rotational. So for these sort of cases, you require special, the innovative approach to deal with this sort of rotation. So we actually look at those vertebrae which were rotated into the same directions, and we connected them with a single rod, and then we derotated them in the same direction. So you can see here I have used the multiple rods, and we just connected those vertebrae which were rotated in the same direction, and we derotated them, the each and individual segment separately, and we could get a decent correction. And I have used the concave osteotomies in this child, and you can see that the amount of correction which we could get is quite nice for this sort of deformity. Coming to the another case, 13-year-old girl with deformity in the mid upper back, and which is gradually progressive. And if you see clinically, this sort of double this thing. And if you look at the neck also clinically, the neck also shows the some amount of rotation. If you could make out, there is a rotation in the neck as well. So these were the X-rays, and again we may argue that this may be some sort of neuromuscular or some sort of syndromic approach, but we couldn't fit it into any other category. We couldn't find anything else. So either we classify it to AIS or this thing. But the point of keeping this case here is that these sort of deformities, we have seen the AIS going into the cervical spine in very less cases, but yes, we are seeing it, especially when they present quite late. So how to tackle this cervical rotation was an issue. So we have used the laminar screw in the cervical spine, and then we use this laminar screw to derotate the spine, and we could get quite a decent correction along with all our usual techniques like the posterior column osteotomies and the concave rib osteotomies for this child, and we could get quite a decent correction in this child. To summarize, if AIS patients, they are caught early, then only the soft tissue releases are enough. And again, you can limit the amount of release required by higher anchor density, and the kind of rod which you are using, the cobalt chrome rod, gives you a much better correction. The posterior column osteotomies alone, they are relatively simple and a powerful tool, especially for the AIS. And if you use them judicially and with a careful planning, you can ensure their maximum potential, and always use the neuromonitoring in these cases. Thank you.